So for our last three movement disorders, we'll first look at Tourette syndrome and recognizing that Tourette syndrome is often has comorbidities for ADHD and OCD. So often individuals with Tourette syndrome are managing OCD symptoms through SSRIs, or those selective serotonin reuptake inhibitors, and they are managing their ADHD symptoms through like we mentioned in class previously, the stimulants or other drugs that target norepinephrine like clonidine and guanfacine. Now, if the tics are not managed through those, then there might be some minimal or mild effects that aren't really going to interfere with daily life, which then the individuals can do more behavioral therapy. So cognitive behavioral therapy or psychoeducation, which may help. But if that doesn't work and the symptoms are moderate to severe, then they might be prescribed the typical antipsychotic drugs, so the neuroleptics that we talked about, like haloperidol or many of the other ones that are going to affect dopamine and be dopamine antagonists. If those don't work, then they might try dopamine depleting agents, so decreasing, again, not just decreasing the receptor activity, but decreasing the amount of dopamine. And then you could also do GABA agonists so that we are, again, inhibiting overall activity. And then if none of those work, you can try the botulinum toxin or cannabinoids, so marijuana or THC. And I don't know if we know how it works, but it might work. And then if nothing else works, then maybe trying some deep brain stimulation. But again, because Tourette syndrome has so many different possible causes that it's difficult to treat pharmacologically. And very similarly, essential tremor, so many different potential root causes that it's hard to find good pharmacological treatments. But one thing is just to let it go untreated, like just shaking a little bit. If it's not interrupting with your daily life, then you might just shake a little bit. But one of the things that does increase the tremor is stress and anxiety. And so often people will use, if needed, alcohol, not the best way type of treatment, but alcohol is a GABA agonist, so it's going to inhibit overall activity. Just like the benzodiazepines are GABA agonists, those are going to increase or inhibit overall activity as well. And then the beta blockers we know are preventing the sympathetic peripheral response of stress and anxiety. Another thing for continuous treatment, one of the things is you don't really want to use benzodiazepines continuously, but beta blockers can be used. And then if none of that helps, there are some benefits for, again, gabapentin is a GABA agonist again. And topiramate is a little bit of a unique one because it has multiple actions. It can act on voltage-gated calcium channels and prevent the release of neurotransmitters. In this case, they say it's specifically glutamate. It can also, or might be, a GABA A agonist, so going to it's going to increase inhibitory activity and decrease excitatory activity. And it also might bind and inhibit some glutamate receptors. So it does multiple different things, but basically decreasing excitatory activity, increasing inhibitory activity. And then just like we've talked multiple times in this section on botulinum toxin, decreasing acetylcholine release to decrease muscle movement. Now, if none of those things work, someone might try surgery. It doesn't always work though. So you can do deep brain stimulation of the thalamus, or you can go in and take out a little bit of the thalamus. I've seen videos of people who have tried this, and they come out of it, and like later they're like, well, that was kind of pointless because it didn't work. So you don't necessarily want to do surgery for something that's only a mild inconvenience. And I know different people are going to perceive their essential tremor as different. And so they might see it not just as a mild inconvenience, and they might make that choice to do the surgery. And our last one, looking at dystonia. So involuntary muscle contractions that lead to inappropriate movements. Again, many different root causes, and so it's challenging to treat. But some of the ones that we have seen before, levodopa, increasing the availability of dopamine, the anticholinergics, so preventing the release of acetylcholine. We have seen benzodiazepines, GABA A agonists, so decreasing overall activity, increasing inhibitory activity. And two that we haven't really seen before, so I wanted to find some images to help you understand what's happening there. So there's baclofen and tizanidine, because we did talk about tetrabenazine, but baclofen is going to be a GABA agonist, but it's not going to be on the GABA A receptor. It's going to be on the GABA B receptor. So just like all activity we've seen before, you've got an action potential in this GABAergic neuron. It releases GABA, binds GABA receptors, and then inhibits the ability to fire an action potential. GABA A is that ligand-gated channel that benzodiazepines can bind to and increase the activity or the flow of chloride into the postsynaptic cell. But baclofen is, instead of targeting GABA A, it's in targeting GABA B receptors, which are G protein coupled receptors that are also going to be inhibitory. So a new one that we haven't seen before, baclofen agonist for GABA B receptors. And then coming back to this tizanidine. So tizanidine is going to bind to these norepinephrine receptors. They are the alpha 2 receptors, and these receptors are going to inhibit the release of glutamate. So they are also going to be an inhibitory neurotransmitter, or not neurotransmitter, but an inhibitory drug that's going to prevent the release of the excitatory neurotransmitters. So tizanidine functioning at the norepinephrine alpha 2 receptors. And then if we move over in our image a little bit, you have benzodiazepines binding and activating the GABA A receptors, and then you have baclofen binding and activating these GABA B receptors. So anything over here on this GABA side, if we are increasing this, we're going to decrease the activity of that motor neuron. And then also, if we are preventing the release of the excitatory neurotransmitter or preventing it from binding here, preventing that glutamate release or binding to glutamate receptors, then we're also going to inhibit this. So everything we've talked about is just inhibiting the activity of these motor neurons. Oh, and if you even wanted to add the acetylcholine inhibitors here, they would just be acting at the muscle instead of at the cell body of the postsynaptic part of the motor neuron. They're acting in the periphery on at that neuromuscular junction. So that finishes it for all the 5 motor disorders. And then what we're going to do in class, you'll notice in your handouts you have this. So looking at the value of targeting heteromeric receptor complexes in Parkinson's disease. And the interesting thing about this is that we've often talked about, okay, so you've got the dopamine receptors, but we really haven't talked about adenosine receptors at all. But one of the things that we know is that these two receptor types, the D2 receptors and the adenosine A2A receptors, co-localize in certain areas of the brain, and the subunits of these receptors can even interact with each other. So we're going to look at this in more detail in class. I don't want to get too far ahead of what we're going to talk about, but the idea is that something that hasn't been used as a treatment before in a disorder like Parkinson's disease can now, or is now thought to potentially relieve some of the causes of Parkinson's disease and even prevent the further death of the dopamine neurons. So we'll talk about that more during class.